Hi, I'm Dr. Hudson Nakamura. I am the retina specialist ophthalmologist from Brazil. Thank you very much for participating with us in another Retinawesome event. We learn a lot with each other in different countries with different techniques, different retina surgeries and the ways we do, and hope you discuss the cases with us and participate. It's awesome to be with you. Thank you very much.
My financial disclosures is only relevant in that I'm a consultant to Alcon and Bausch & Lomb, but in Bausch & Lomb's case, only their pharmaceutical division, not their surgical division. So we all know how to do macular holes, and the success rates of macular holes have become better and better over time. We're up in the higher than 95% rate. In some years, we're up around 100%, especially using some of the techniques we do currently. But what I'm talking about today is these complicated macular holes, and I really just put them into three different categories: large holes, large and chronic holes, recurrent holes, so holes where the surgery wasn't successful, and finally macular holes and very high myopes. These are all much more difficult. You have to use different techniques to close these holes. So the first are large holes. So large holes, by definition, more than 400 microns in smallest width, not greatest width, it's smallest width. As in this case here, this is 516 microns at the smallest width or aperture of the macular hole. And if you look at studies, holes that are larger than 400 microns, the success rate is significantly different than those that are smaller than 400 microns. It's a study we did at the Cleveland Clinic where the closure rate was only 75% in these larger holes. Now, this is an older study. We need to actually redo this study with some of the newer techniques, but there was at the time a significant difference in closure rates based on hole size. So really, what has come to fix these large holes? Well, the key sort of trick is the ILM flap, and this was described a few years back, but the way I do an ILM flap may be a little different than it was first described. So first of all, I like to have the ILM flap temporally. So I like to make the edges so it's temporal. And the reason for that is when you do an air fluid exchange with a temporal flap, just the physics of the fluid coming across the hole pulls the ILM flap over the hole. So you don't need to actually do any manipulation of the flap. It just covers the hole after you go to air. I don't do some of the things that I've seen videos of where people stuff the ILM flap into the hole or do it from all the different sides, temporal, nasal, superior, inferior, and just like cover the hole like they call it like a rose petal. I don't agree with that. The whole goal of the ILM flap is to give you a scaffolding to cover the hole, as shown in this video that Carl O made, to allow the edges to reapproximate, so that you do not need to stuff it in. And in fact, if you stuff it in, you're making almost like a plug to help to prevent the hole from closing. So in Carl's case here, he covers the hole. I would have peeled the edges to make it more of a sort of like a pie shaped from the hole. And the other thing he didn't do, which I do in this video, is I peel all the other ILM edges also. So in this video, he only peeled the flap. I personally peel the flap as shown here and very nicely covering the hole. But I also peel the ILM on all the other sides. I don't leave it like Carl did in this video. But I like the schematics. So that's why I use this video. Using this ILM flap technique, the hole closure rates have dramatically increased in historically as well as in the published literature. And so it's coming close to sort of what we get with smaller holes in terms of closure rates. And it also works very well, obviously, for myopic holes, which we'll cover in a moment. But this is a very good technique. Some people have advocated, especially in cases of previous surgery, using a free flap. The problem with the free flap is it moves too much, and so it's difficult to prevent it from moving when you go to air. Some people advocate leaving PFO in the eye to do that. I don't agree with that, not in a macular hole case. And I think some of the other techniques that I'll show you are actually better. As I mentioned, I don't like the idea of stuffing the ILM into the hole. It's sort of like when we used to use autologous serum in the past. That would cause a glial plug and prevent the hole from closing. You want that whole area to close nicely. But here's a case of an ILM flap. It was done under PFO. And obviously, you can see the ILM had been peeled previously. This is a recurrent hole. But for me, I like to use a different technique, which we'll talk about in a moment. But the goal here is, as you can see, is they're just stuffing the ILM into the hole. And as I mentioned, I'm not a big fan of this technique. I use a very different technique than this. I think this leads to too many, anatomically it looks good, but from a visual standpoint, it doesn't work. So the other sort of way to treat a very large macular hole, and when I say very large, these are more than 1,000 microns or very chronic, is a technique that was developed by Tamer, which is a full thickness retinal patch graft. And some of the tips to doing this are, first of all, you need to use small gauge, but you need to use valve cannulas because it's very important to really control the flow while you're doing this. You don't want high flow states. It's really absolutely necessary to make sure that all the ILM has been completely peeled so that you should use a stain to do that. Most people will use either a cautery or endolaser from the donor site. I personally use endolaser, and I do use cautery for large vessels in the donor site. In the video I'm going to show you, I did not inject BSS under the donor site, but since I started doing this now, I do use the 41 gauge cannula to subretinally elevate the donor site before I cut it. And then I put the PFO in later. I do use a vertical scissors to make the patch graft because I find that to be very precise to really make a nice circular area just slightly larger than the site that you're going into. So the donor should be just slightly larger. And I think the really important thing is this. Some people try to do this without PFO in the eye. You really need to do this with PFO covering the donor site. If you don't do this, the donor very difficult to peel and place into the chronic hole site. So just showing you, here's the case. I like to do it with a chandelier. You can see the chandelier there. Oops, what happened there? Let me get my picture back. There we go. So you can see the chandelier here. This was a high myope. You can see how long the eye is. So endolaser, the donor site, place in this case, this is an earlier case, placing the PFO. Here you can see the PFO being placed, and it's pretty full PFO. Then making the donor graft here using a vertical scissors, which makes it a lot easier. I find I've since changed to doing this part without the PFO in the eye because it's a little harder. But this particular portion where you're peeling the flap and placing it in a hole, that has to be done under PFO. So you can't do this without PFO and then just kind of placing the graft in the donor site. So and then going to air. I personally like to use C3F8, but others have advocated leaving PFO in. And here you can see it afterwards, using silicone oil or gas. And I personally like gas. That's what I use myself. Here's just some examples. This is actually from a talk by Steve Charles. The thing that a lot of people ask is anatomically, these cases look really, really good, right? So these are very large chronic holes. And you look at the OCT and you go, wow, that looks amazing. I don't think visually it's as amazing the results as it is anatomically. Some people have said that the graft recapitulates and there's some connections between the graft and the original retina, but I don't think that's actually true. Now, there is some improvement in vision because the size of the hole has gotten smaller from the patch graft, but I disagree that the visual acuity results in these cases aren't spectacular. It's more anatomic. As I said, I use C3F8. In this case that Steve was part of, the majority were silicone oil. I think C3F8 actually works better than oil for these cases, and I don't ever use PFO, leaving PFO in the eye. But the success rate in these incredibly large holes in this case series was actually pretty good. 90% success rate, and these are very large holes. So it does seem to benefit. Recurrent holes, there's sort of the recurrence rate has been in the literature anywhere from 3 to about 10%. And this is especially high recurrence rate if you do cataract surgery after macular hole surgery. I personally, for my primary holes, always do it as combination. I do have a cataract surgeon come in, do the cataract surgery. I do the macular hole surgery, so it's at the same time. But if you do cataract surgery after macular hole surgery, maybe a year after, you got to be very careful about CME. So you tell your cataract surgeon to make sure to use non-steroidals to prevent this from occurring. So what are the tips for a recurrent hole? Well, the key thing is to see what happens. So most of the recurrent holes that I have to treat are not from myself. They were sent in. And so I don't really know what the previous surgeon did. So I do a very good ILM stain to figure out what they did. If the ILM peel wasn't too large, I'll show you a flap technique. If the ILM peel was huge, they went all the way out to the arcades, the first surgery, then it's very difficult to make an ILM flap in that condition. And so what I've started to do, which has been very successful, is to create submacular blebs. So I use a 41 gauge cannula in 4 quadrants around the macular hole to basically make the hole mobile. And when I first saw this technique, I said, there's no way this is going to work. I don't understand really why it would work, except to allow the hole to become more mobile. But lo and behold, especially these recurrent holes where there's no way to make an ILM flap, it actually works very, very well. So, it's just similar to a translocation or subretinal surgery. You just use 41 gauge cannulas. The reason you have to make 4 of them is because, as you're injecting the fluid in one quadrant, eventually it'll make it all the way to the hole and the fluid will just come out the hole. That's when you need to move to the next quadrant to start the next quadrant. You really want to kind of mobilize as much of the retina around the hole as possible. And because the fluid will tend to go towards the hole, you don't have to worry about making some large submacular detachment. It won't get that large. The other thing is if the ILM flap that was performed already wasn't very large, you can actually make another temporal ILM flap where the hinge isn't at the hole. The hinge is at the edge of where the ILM was peeled. The key feature of that is the distance between the hole to the edge of the ILM flap. You need to make the flap itself larger than that distance so that the flap covers both the previous ILM peel as well as the macular hole. And it's actually easier to do than it is to describe. You do need a good staining of this area, and the ILM is thin in this area, so it is a little difficult, but it actually works very nicely. And if it doesn't work, then just go ahead and use the subretinal bleb technique also, or in some cases I use both, either one. High myops is the other difficult one because of posterior staphyloma, very thin and RPE atrophy, thin choroid, very RPE atrophy makes it difficult to oftentimes see. Need a good stain. And in very high myops, it's sometimes hard to even do the peel because you can't actually reach the retina. One of the tips and tricks I use for that is you just take the cannula out. because if you take the cannula out, you get an extra 2.5 millimeters of play to actually get into onto the retinal surface. But these are the cases I'm talking about. Patients with a high myope, they may have a foveal detachment associated with it. And in this case, the idea is to produce a macular buckle. You need to do something to push your staphyloma up to help close that hole and close that little foveal detachment. So one of these techniques that I developed about 15 years ago was to use a sort of temporary macular buckle by injecting a viscoelastic behind the eye, right underneath the macula. I did this originally under intraop OCT guidance, but I find that you really don't need to do that anymore. I've also, in some cases, there's a filler that our plastic surgeons use that lasts longer than Helon does, for instance. And so in some cases where there's a very large staphyloma, I'll use the plastic surgeon's filler behind the macula. But this just shows you, some of the post-op day one, you can see how that posterior staphyloma is being pushed forward by the Helon behind the macula, and that helps close the hole. Obviously, in these cases, we peeled and also did an ILM flap, but in many cases, you have to add this additional posterior buckle effect to let these things close. So, I've showed you many different techniques to use in these very complicated holes. Hopefully, some of them will help you with the cases, but I was asked to present a case for the panel to discuss, and so I wanted to show you this case. This is a patient who had a macular hole from trauma. So they were hit in the eye at a major league baseball game. A foul ball hit them in the eye. So you can see the choroidal rupture there. And the choroidal rupture, as well as the trauma, led to a traumatic hole and then a second hole right next to it. So I'm curious to hear how the panel would recommend we fix this.
Wow, this is a double macular hole. It's pretty interesting. And maybe the first idea would be just to put a PFC because actually we cannot cut the structure. And maybe after trimming the internal, all the attachments over the hole and then leaving that central area intact, if you go peeling from peripheral to central, and then I think if you get to remove the ILM, I think both sides could close because actually the right side is half closed. So I wouldn't do anything but try peeling the ILM very carefully over those areas.
Yeah. Anyone else? That's a great idea. You definitely want to peel the ILM, but I agree with not peeling the ILM in that little area between the two holes. That would be a little dangerous.
That's great stuff that I've looked at. It's almost everything that I've seen all around the world, and we just saw it in a few minutes. So congratulations for a beautiful presentation. For this particular case, I would do two surgeries. I was destined to do two surgeries. The first one will be to buckle and close with tamponade the remnant, the central remnant with the right one. As I look at it, because they have a very small area to work. And then when I finish that and they get closed and I forget the other one, and then when I finish that after a few after further time, I would go for the second one to peel the ILM on the left side and cover it up with the way you do. And I would do it in one hand because you might traumatize it more and you might end up in trouble with that. It's my idea on that.
Yeah, it's a great idea. Well, I'll keep you out of your suspense. So what I did was basically I flapped where the flap edge was on the temporal hole, which wasn't the true macular hole, the foveal hole we'll call it. was the true hole. The second one was due to the choroidal rupture site there. You can see that the ILM has not really been peeled between the two holes, but on the edges of the foveal hole, I've completely peeled it. And this is almost like what I do in the recurrent holes, where the ILM flap has to cover both the ILM peel as well as the hole. In this case, the ILM flap is large enough to cover both the hole. Both holes are covered by the ILM flap, and so that's what we did, covering up both. And here it is pre-op, and here it is post-op, where you can still see the choroidal rupture, but both holes were closed. So vision improved some, not great because of the trauma and a choroidal rupture. But 2200, I was pretty happy with the result. So I hope you guys enjoyed a whirlwind tour of complicated macular hole surgery.
This was really, really nice. Saad did a retinal fellowship with me back in Toronto years ago. He's a very good friend of mine. Saad, would you like to comment on Dr. Peter Kaiser's case?
Sure. First of all, it's great to see you, Peter. And this was a great presentation. You've covered, most of these stuff we might see with macular hole. And I think that last case is amazing. I've never seen a patient with such a complicated macular hole. But at least now we know when we get complicated holes, where do we send them? So thank you.
No, you don't have to send them to me.
And Mohammed, I've seen nice cases from you and in many media sources like Instagram. And I know you are very familiar with Mac holes. And could you comment on those cases?
First of all, it's a great honor for me to be among all of these professors. Thanks, Dr. Peter, for your great presentation. For me, I will deal with such a cases as a two double macular hole. Every single hole, I will cover it by a different modalities. Like if I have the main hole of the main foveal hole, I will cover with a nasal ILM flap. And the temporal hole, I will cover it with temporal flap. If I succeeded for this, I will do this. If I fail, I cover one of them with any patch of flap surgery or patch surgery. Like if I succeed for the main hole with the ILM flap, it's okay. The temporal one, I can get a retinal graft. So I deal with two different holes as two different cases, like we have two holes. So intraoperatively, so we will see if we succeed for ILM flap, go ahead. If we will not succeed, we will research for any flap. Any material cover this hole, both of them. Yeah. So it's a great case, by the way. First, for me to see this large double hole in the same case.
Sasamoto, Marcelo, my friend, and a nice case.
Thank you.
And I would like to comment. How is the time in Bolivia? Everything is all right in Santa Cruz?
Everything is all right. Yes, there's no conflict at the moment, so we are pretty in peace. Congratulations, Dr. Kaiser, for your case. One of my questions is, did you think of performing some relaxing incisions around the macula is another option to close? I don't know if you had experience to made it. Also in high myopes, you perform sometimes relaxing incisions. So what's your experience about that?
Yes, I like using relaxing incisions, especially in recurrent holes and chronic holes. And by relaxing incisions, I mean just make some sort of nicks in the edges of the hole, just in case there's like an annulus, a ring of scar tissue around some of these chronic holes. So by just cutting the edges, you can break up that ring to help the hole close. In this case, it wasn't actually that old. The hole, it was more traumatic. Even though the choroidal rupture looked relatively old, we probably operated only about a month or so after the trauma had occurred. So in this case, I just did the ILM peel, and I did a very big and a very aggressive ILM peel, as you saw. but I did not nick the edges. But I think that's a good idea, especially in chronic holes. So I do use that technique. And again, none of these techniques are mutually exclusive. You combine what you need to do to close these holes. And some eyes you have. It's sort of like I tell my fellows with diabetics. The eye gives you what it wants to use to. You just need to know the different techniques and decide which technique you're going to use on that particular hole, because not every hole all the techniques work.
I like a lot doing the inverted ILM flap. Oftentimes, I use the PFC as a tool not to let the ILM escape, and sometimes that happens and I have to move it back again if you plan to do the stuffing technique. But when I peel from temporal towards the hole, the ILM, you just insert it and you keep a stalk in the periphery, so it never comes out. And I like using the PFC, and it gets the ILM more stable. Some people don't like it, but when you get the ILM, the PFC weighs in on retina, and it keeps it stable there in case you just let it escape and you just get it back. It works pretty well. And what do you think about it?
No, I agree. Like I showed you with Oswald's video, having a PFO definitely makes the movement of the flap much more controlled, and so because of that, it's easier. And I agree. In these recurrent holes, PFO can sometimes be very, very, very useful. I think one of the things like in Carlo's video, I don't make the ILM flap that way. I actually first make the edges, so I peel from the hole to the periphery. So I have edges, so sort of the edges are made, and then I peel that last part over the hole. And now because I have the edges already made, then I could peel all the way around the rest of the hole now. In Carl's case, he did not do that, and I disagree with that. I personally peeled the rest, so the only area that's not peeled is the temporal area where the flap is. I find that works actually better on these large holes.
Okay. Natarajan, are you around? You want to comment on Dr. Peter Kaiser's cases? And if not, VIPHAB, because I know you have another meeting going on, and you are going to present some related cases concerning macular holes. Would you like to comment before you present your case?
Yes, wonderful presentation, Dr. Kaiser. It was lovely to see the double hole case as well, and never seen that before. Just a question, when you do that retinal tissue transplantation, do you place the patch graft over the hole, or do you kind of tuck it inside the hole? And what is the technique if you're placing it over the hole so it stays there? What is the tip for that?
So I do place it in the hole because you're correct. If you place it over the hole, it's going to move. In that case, you have to leave the PFO in the eye if you're going to place it over. Otherwise, it will move. So that's why I make the donor just slightly larger than the hole, and that way the edges kind of go underneath the hole, and the edges hold the donor underneath the hole because I take the PFO out and go to gas. And obviously you want to do that incredibly slowly with a very, very low vacuum to avoid disrupting the donor. But yeah, so it's just slightly larger. It's not a lot larger. And you place it underneath the edges.
Okay, VIPHAB. And thank you again for all your comments, Dr. Peter Kaiser. We are always learning how to do the best thing for MAC holes, especially those, the large macular holes. And what is your experience in amniotic membranes?
Yes, I personally haven't used amniotic membranes. I've seen people use it. I think it works very well. The issue, of course, is sort of like an ILM free flap. It's making the amniotic membrane stay. You want it to stay over the hole. Again, I don't like stuffing things into holes. So because of that, you're just basically laying the amniotic membrane, and you need to use something to keep it there. And so most people will use like PFO or do a PFO silicon oil exchange to try and prevent the amniotic membrane graft from moving from over the hole. To me, it's just an extra expense. ILM is free. I just got to use it from the eye that I'm already using it from, so that's free. So in general, I don't use the amniotic membrane. I use ILM.
All right, it gets free. And if we get, this is your subject, we all know that you are very keen at those studies, but if you think genetically thinking, if you want to align the RPE, the whole structure of the macular hole, do you think in the near future, or maybe longer, we could think of injecting something below the ILM, for example, and not just creating the scaffold for the hole to get closed, but the whole structure to align, such as the RPE gets everything aligned? Do you think there's anything thinking about this regeneration in the near future?
I mean, it's possible. There's others have thought about using is if there's something almost like a tissue sealant that you can put over it. So if you go to air first and then put a tissue sealant over, has been tried. But all these techniques, especially the tissue sealant, some of the tissue sealant gets into the hole, and if that occurs, again, that's sort of like a plug. So it's hard to say what some of these newer techniques you described, if they're going to work or not. I'm not sure.
Okay, thank you very much again for teaching us and sharing with us and discussing with us these cases. And this was really a gift for our audience here, and also your lecture will be in our channel so that we could discuss more. And I would like Vaibhav Sethi, if you want to share your screen and present your case, please do so.
Thank you very much. Can you see my screen?
Yeah, it's pretty clear.
So I'll be presenting a short, interesting case, a problem that I encountered intraoperatively. This was a young patient, uncontrolled diabetic who came with vitreous hemorrhage, and this is how the surgery went on. So he had a clear lens. So
Looks like the video is not moving, Vaibhav.
This fibrovascular tissue, the peripapillary tissue, was quite dead, and I was not able to find a proper cleavage plane. So I tried to use my max forceps in whichever way I could to cleave off and pull this off atraumatically, this stalk of fibrovascular tissue. So this was quite vascular, and I did somehow was able to tease off this tissue from the optic nerve head, and just gradually trimmed it and peeled it, sheared it off. But now started the main issue. So the problem was that after trimming it off from the optic nerve head, which I was successful as, and the residual tissue was carefully trimmed off. Now there was a small hemorrhage that happened over the optic nerve head, which I raised the bottle height, increased the pressure to around 60 for a minute, waited for some time for the blood to clot, and just cleared off some amount of blood around it. I went ahead, did my peripheral base shaving, cleared off the residual hemorrhage whichever I could, preventing any lens touch, and this is what happened in between. So what's happening is that particular focus of bleeder is oozing out, it's bleeding as and when I'm doing. So I did not pay attention to it. I cleared it off in between. I came back and I saw the same status happening every time there was a thick plug of hemorrhage forming over the posterior pole. And though I peeled off the fibrovascular stalk, this bleeder didn't stop bleeding. This just kept on bleeding again and again. Even after raising the pressure for as long as possible, I could not raise it further on. So what I did was I went into air. I trimmed off the clot over the optic nerve head, and I left a small clot there in itself. So post-operatively, the patient had a vitreous hemorrhage that happened initially, and I've been following up the patient since past 2 or 3 months, I would say, and gradually the hemorrhage has cleared off from the center, giving good visual recovery, and it's now settling down. So my question to the panel would be, how would they have tackled this problem differently, intraoperatively? Thank you.
Yeah, it's not uncommon, but you know, I like cleaning the vitreous the most, and you did the right thing. You did laser, you did the whole thing. But at the beginning, I usually, after I clean up the vitreous, I like using very often the perfluorocarbon, because the perfluorocarbon helps me halt all these tiny little hemorrhages, especially those hemorrhages that halt you from getting a good view from the posterior pole, and that works pretty well. But the case was pretty well conducted. Would you do anything different, Saad?
Yeah, no, this is a great case, Dr. Sethi, and I think, you know, in these patients, I think there's always this chance that you'll have this vascular disc, and I think you don't really have to peel it. If you take all the traction around it, maybe it's not a bad idea just to leave that stock and it will just involute. But I know as a surgeon, you want to go in and pull it off, and that's what we see. I think not using endodiathermy is a good idea, because you want to be very careful on using endodiathermy on the optic disc. And I think doing laser is good. Going for air was great. The only thing I would have thought of different is maybe if I think this case is vascular, I might have pre-treated the patient with anti-VEGF, or even intraoperatively at the end of the surgery, I would have added some anti-VEGF. Great case, great case. Thank you, my dear.
Yeah, that's cool. And Mohammed, would you like to present your case?
Yes, sure.
So what meeting you have now, Wahab? You're leaving for, you said you are too busy with preparing those lectures all over, such as us. And where are you heading?
It's not a meeting. I go for a family function.
So you can see my screen now?
Yeah, it's pretty
Yes,
clear.
we
Yeah.
Yes,
You use
perfect.
this Ingenuity always, or just sometimes?
No, it's 100% of my cases I work at Ingenuity, either phaco, vitrectomy, anything. This is the standard now for me since 1 year and a half. So I will present this case of complicated retina detachment for a young boy, 15 years old, with complicated cataract. I removed the cataract and starting the vitrectomy by this view of a bullous retina detachment with subretinal bands. In such cases, I usually fail to inject a Keynote to attack the posterior hyaloid. So instead I put the BFC and injecting the triple blue and starting attacking the ILM and the posterior hyaloid at the same time, removing the posterior hyaloid under the PFO to keeping the posterior pool flat. Under the BFC, you can attack also the posterior hyaloid stained by brilliant blue or tip blue, and extending the ILM peeling as much as I can, remove the PFO to attacking the subretinal band. I decided to attack this band by small retinotomies, either large retinectomies to remove to working subretinally. So I just do a small retinotomies, going for the lower band, relieving this band by assisting the left hand for the retina to get it free. When I feel that I just cut it, I leave it the rest of the membrane. Good for the other one. Also the small retinotomies over the membrane, relieve the upper one. And I feel that I may go for the other membrane to release it completely. But as you can see, I feel that when I cut the membrane, so leave it alone. So the retina now become more mobile. And I feel that we can go shifting for air to flat the retina through the posterior retinotomies that I did. But actually, when I dried the macula, I feel that the retina is totally detached with the air. And now the retina is closed by pull-less detachment, and all the air is coming under the retina. At that time, I feel that what's the cause of this point, why the air is going under the retina. So we have one reason: the retina is shortening and the retina is tracted. So I just do a small retinotomy in the anterior retina, trying to remove the air in the subretinal space. And from that point of retinotomies, I feel that so we can remove the rest of the membrane being on the anterior retina, subretinal anteriorly from this membrane. But actually, when I remove this membrane, I feel that the retina is antero-posterior tracted. I don't know what's happening for that shortening, and the air is coming under the retina. But by the indentation, I feel that the retina is incarcerated at the area of infusion. The retina is incarcerated at this point. And I feel if I relax this retina by like 2 to 3 clock hour anterior retinectomy, I will succeed to flatten again. When I put the PFC, again, the retina become flat. And I didn't do direct PFC silicone exchange. I do PFC air exchange again. And I succeed to relax the retina by do like 2 to 3 clock hour lower and the lower nasal, lower temporal and lower retinectomy. As you can see, I go for the air again and drying the edge of the retinectomy and removing all the air and put the silicone oil 2000 for such a case. For me, when I reply this case a lot of time, I need to know where is the problem, why the air is coming under the retina. And I need to know from your panel, from the panelists, why the air is coming under the retina.
Very cool. Yeah, actually, you have to find the reason why, and I was just concerned why did that air came into the subretinally like that, and I think you managed it very well, because I would probably do a small retinotomy as you did to search for reason, or if there were anything inside, or even I could start with more PFO. So I would squirt the air out of the retinotomy. But the best thing was to find, as you found, this place where there was this incarceration. And when you found the incarceration, you relieved it, you did not need to do too much of a retinotomy. So you did economic retinotomy, and that was cool. Even though the retina was short, you could manage it very well with PFO later and attaching the retina with a very good-looking retina. And VibeHab, what do you think? This is a great case, no? Very good, and the imaging as well.
Very nicely done, and I think you recovered very well. It was a tough situation. Also, maybe the young patient had a dialysis, it's possible, and the infusion somehow during the surgery would have directed the air underneath the retina. That could have been because the primary cause for detachment, was because it's so bullous, we could not see the primary break, and that lies. That could have been the real reason why there would have been a sudden gush of air, because air would have just lifted up the retina and caused the subretinal detachment, which happened in this case. But very well managed. And then there was incarceration at the infusion port.
I totally agree with you, Vahab, because I think it's the only acceptable reasons for me. Because if it is a retinal shortening from the start, why it's become bullous detachment from the start? And also, when I remove the subretinal bands, I feel that the movement of the retina is a little bit free. So I didn't feel that it is shortening. I think it's what the original part of the etiology of detachment is some sort of retinal dialysis at that point, which are closed already by the PVR or something like this, and the air is and the infusion canal is coming behind the retina. I think it's an acceptable point of view to put it in the stage.
In general, as usually, you showed us a very beautiful cases and a very difficult one, and you always show us a problem, how you solve it. But in general, the physics of the fluids, and silicon oil, and perfluorocarbon, and air, is that the surface tension of every bubble you put in the eye, if it's increasingly more than the surface tension of a hole at the level of the retina, then everything is going to go behind. So it's a physical problem that always you have to counter the surface tension of the tear according to the surface tension of the injectable, whatever you're using. The problem here is that how to calculate that, and that's what you did beautifully. You just remove all the traction from everywhere. So if there's no traction at the tear, that's why you see sometimes with perfluorocarbon, you go through the retina and you go up as far as the tear, and you go above the tear, and perfluorocarbon doesn't get in. But in other cases, when you go exactly at the tear, then perfluorocarbon goes behind the tear. So the difference is the surface tension of the tear. And a dialysis, when you have, it's the surface tension of the tear, of the gas is much more than the surface tension of the dialysis. And it's very easy to go behind. But you tackle it beautifully. And it's always nice to see your videos, because I'm always taking something with me at the end of it.
Thank you, Doctor.
Yeah, nice, really nice presentation. And I would like to show Athanasius. Can I display your case next?
Yes, because I don't have my laptop with me anymore.
Yeah.
I just broke it down and you have to use my presentation. I was lucky that you had it. And this is a case that I would like to show you that it's happening 15 years ago. Everybody thinks that we have a lot of innovations at the time that things are happening. So we got a 6 months old retina detachment.
I think this slide.
I don't see it.
I don't think this presentation is complete. This one has only one slide, so.
A video, yes. You go to the next one. You can go to the next one.
Okay.
So easy.
Let me get the other one. Just a moment here.
Well.
You want the zipper one?
Beautiful picture here. Well, whatever you feel it's comfortable for the people that they see it. Well, the zipper syndrome is a new thing that it's happening to every one of us, and we just call it zipper. Next one. Can we have the next slide, please?
Sure.
And what it's all about zipper syndrome is that the vitreous base, this is Thessaloniki where I live at. It's a city, and I would love to have you there sometime. Next, please. You know that the vitreous base has a place in the eye anatomically, and it's 2 millimeters ahead and 3 millimeters behind. And that's usually what it is, where the vitreous it's incarcerated in the retina area, and it's very hard to remove it. Usually there's the problem when it's happening. Next. But sometimes there's an irregular posterior vitreous base, which goes even behind 6 or 7 millimeters, almost near the equator. Can I have the next slide, please? And this is important because this that is sitting next to the equator, that means that when there's a traction there, you have multiple tears happening, and at the same meridian, one after the other, and that it doesn't have to be. And average distance is 7.6, and you have a very difficult task in order to buckle them all together and to remove all the traction. Next. So, multiple tears in one meridian, a retinal detachment without actually PVR. The same plane tears also in attached retina, and a posterior base insertion. They give the impression of a continuity that acts like a zipper that's given time is going to open all of them, and it's going to transfer to giant tear. Next. Consideration. Vitreous saving must be difficult because you have to save every tear completely. And traction should be removed from all tears, but traction at the vitreous base is very difficult to tackle. So you have a very high redetachment rate, and you have to close all the tears. Next. As you can see in this short video, we have a simple retinal detachment. Can you just start the video if it's playable? I don't know if it's going to start on your side. Yes.
Flowing good, flowing good.
Showing good, okay. And you start like vitrectomy, and then you find that there are multiple tears, even in attached retina. And then this is the important issue of this video. When you go at the vitreous base, near the vitreous base, the periphery, to remove all the cortical vitreous in order to inject some fluid gas inside, then you're going to see there's a band actually that is at the inferior part of the vitreous base. You can see, and it's uncuttable. You can chew it, and it's so elastic and so strong that it's not cutting off. Can you see this band? That is, this is a posterior attachment, beautifully shown in the video. I never had it before, so obviously that it goes all over 360 degrees around the eye, and it's very difficult to remove. Here you can see it even more nicely. I don't know if we can distinguish it completely. So what to do in these cases when you find a case like that? And this is where we tell you that whenever we had this case, we have few cases like that, we used to do dual surgery. That means we use a buccal surgery and a vitrectomy. Because they are all the same. Next one, please. The next video. The next slide, please. So the treatment is, if recognized, a simple primary vitrectomy is not enough because we have a higher rate of detachment. 360 laser, another 360 buccal indication, and citriafate. We notice something different in a difficult case that it doesn't show it's going to be difficult when you start with a simple retinal detachment. Next. Well, I think that progress comes from doing the unconventional. Next. As Macular used to say. Next one, please. And this is my friend, my late friend, Cesare Follini, which dedicated the whole school that we did together in accordance with Retinawesomes this year. This was done in Thessaloniki in July. Next. So it's called Thessaloniki VITREORETINAL Summer School. And you can see here people that with ingenuities to train on exchanging lenses, with Carlevale in the middle showing how to put a Carlevale lens. And everybody is looking at him. Next. And this is the setup. So moving and showing technology that is talking about everybody, like they don't have access to do a true wet lab where actually everybody is doing and using the latest innovations of continuity. Next. In an environment that you wouldn't have access otherwise, because everybody cannot have an access. The next one is going to happen together with Retinawesome on 2023, July 3 to 7. And the last one was just a few minutes ago. And this is the setup, actually, you can see with the biome, and the bionico eyes, that you can actually represent a true-to-life wet lab where we can train people that they would like to do retina with the latest technology techniques. Next one, please.
It's interesting.
That's about it.
Athanasios, when you showed the posterior edge of the retina, it was pretty flat. And for me, that was, enough for the surgery. I would do laser around the edges and maybe an air fluid exchange with gas, since it was not, the retina was attached. So would you do that, or just leave the air and go for another buccal, as you mentioned? Because the case was so cool. I saw the edges of the retina, everything was attached. And so I remember this case because you are talking about the zipper syndrome. I remember that Sasamoto already showed some cases of zipper syndrome. And how did you manage this case and other cases when you have that edge so flat on the retina? What else could you do different if you don't have many holes?
Well, the thing is, when you finally understand that there is a posterior base that is implicated with the retina tears, when you have the retina tears one after the other, and you see the posterior base, that it's almost unremovable and uncuttable. Also in the flat retina, we have, as we've said before, twice as much redetachment rate if we did this just flattening 2 or 3 tiers and put some air than we would have if we put also behind a buckle, a 363 millimeter sponge buckle. Because you need to support this traction, because this traction is going to continue. And it's going to continue even at the area of the tears that already is not removed. And that's the issue of the posterior vitreous base. You don't go so far ahead when you have a normal detachment and you have equatorial tears. Here, the equatorial tears are connected with posterior vitreous base. And that's the most important issue that I want to present. If you just put a 3 millimeter buckle, and if you'd like to do a vitrectomy, it will do much better at the end, and you're not going to have secondary surprises.
And if you saw that during your surgery, then could you place just a 240 band, for example, after vitrectomy? So let me move back to the microscope. Let's just put a 240 band, and you think that could solve well, create indentation, support
yes,
the
because
edges?
We have just everything in one meridian. If you just point out which meridian is that, 6 millimeters, 7 millimeters meridian, you just put a buckle at this area, 6 millimeters around the eye, and that's about enough. Because you contradicted the traction that is going to be there at the end of the operation. You cannot, that's the point, the whole issue. You cannot remove the traction from the equator completely. There's no way. You show that the vitreous, the cutter was hanging on this traction and it was chewing that like a gum without being able to cut it. And it's a very strong vitrectomy machine we've got, 10,000 cuts per minute. with current.
All right. Beautiful, beautiful case and beautiful imaging as well. And would like to comment on this case, Sasamoto, or because you presented some zipper cases that I loved too in some of our Retinawesome meetings, I remember.
Yes, sometimes I presented with a sponge, but usually I prefer now the silicone 240 for these cases. But
I'm using a sponge, 3 millimeter sponge all the time, because it's easier for the fellows to put 4 sutures in a 3 millimeter sponge, because they don't have to pull it with a 240 band. You have to pull it, and you don't know, each one is not prepared to know how much to pull it. And we're in trouble sometimes by fellows to pull it more than they should pull it, and we have anterior ischemia on band. You will never have anterior ischemia for putting a 3 millimeter sponge around the eye, because you don't have to stretch it. Just suture it there in 4 quadrant, and it's going to push enough buckling energy to remove the traction from these eyes. That's my idea. It's not clinically proved, but I really, with my fellows, I'm sometimes in trouble how much they're going to pull the band.
yes, that's really that's true actually. But I prefer now doing with the silicone. But I think it's I'm congratulate you, doctor, because all the fellows need to learn these types of options that they have in the future, you know, to future cases, complications. So congratulations for teaching that.
That's why we have this Thessaloniki VITREORETINAL summer school that we try to use. Now we have been 11 years, and we have more than 300 ophthalmologists from all over the world training in exchanging lenses, cataract complications, putting a band, and always we need this technique to be there. We don't want to remove the technique of knowing how to put a band in the eye. We don't want to hear it obsolete. There are certain indications, especially in young people, that they should not do vitrectomy, that the buckle is very essential to have. So it has to be done in the fellowship program. It has to be there. They shouldn't remove it. Especially now that you have the infusion, that you can use the endoscopic light, because people are not very accustomed now in the indirect ophthalmoscope. It's very difficult for them to do an indirect ophthalmoscope surgery. But now with the endoscopic light, they can do the whole procedure, and like they know it. So it's just techniques, how to put a band, how to use it, how to train in the eye. I'd love to do that.
All right, then.
Great, doctor.
Thanks, Athanasius. Always good teaching as well, and considerations. And I would like to call Natarajan for presenting his case. Thanks, Natarajan.
Thank you, Hudson. Thank you, Athanasius. I enjoy your presentation. Your video was great. In spite of you lost your computer and Hudson helped you. So I'll share my screen. So it's a 3-month-old baby, and the one eye was totally normal, which I'm not able to explain, but I had a ROP in the other eye. So it's a 3-month baby, which was I just operated last week, who came from Dubai with one eye ROP. So the child had a Lucentis injection on 9 June, and I had a ROP stage 3 with zone 1+, and right I had anterior zone 2 and no ROP. So birth history was a cesarean section, 33 weeks premature, birth weight was 1.5 kg, in NICU for 28 days, and no consanguinity. Fundus examination showed a thickened hyaloid over the optic nerve head with peripapillary and macular TRD, and temporal peripheral avascular retina with elevated ridge over 6 clock hours, temporarily having florid neovascularization, stage 4B ROP with a nasal retina normal. So we advised surgery. I did a 27 gauge vitrectomy. So this is, I just took a 1.5 to 2 millimeter from the limbus, the 3-month-old baby, and using the 27 gauge pars plana entry. Fortunately, since the 4B, you can see the optic disc and the stretched macula, and there's a vitreous which is being pulling on the periphery of the avascular retina and the vascular retina at the time. So we planned a vitrectomy, and you will be seeing like a thick stick vitreous. So I used steroid to stain the vitreous. And I make sure that there was no PVD, so it took some time. Had a 10,000 cutting rate with a 27 gauge. It took some time to remove the vitreous gel, but I think patiently you have to do this. You can see the vascular part which was there was having a mild ooze, so I didn't increase the intraocular pressure. Intraocular pressure was kept at 20 all the time. I'm using the vitreous 27 gauge forceps to do the membrane peeling, and at one stage I realized that the membrane was quite thick, and you can see the vitreous which was attached was giving rise to some ooze. Still, I didn't use the increase the intraocular pressure. I didn't want the optic nerve to be compromised for even a few seconds. I managed it, and I used PFCL to press the retina, and then under the PFCL, I used the forceps to peel off the rest of the membranes, and also try to release the traction in the peripheral retina, and whatever ooze was there, I used the cutter to remove the blood. So after I released all the traction, removed the membrane, this is under the PFCL, using the catching the membranes and removing it. And the idea is to remove the membrane and then leave the folded retina as it is, so with time it should go back. So after the membranes have been removed the PFCL, I used the retinal brush and did a fluid air exchange, no gas, just left the air there and removed the pre-retinal hemorrhage which happened, and now injecting the eccentrics at conclusion. So I removed the 27 gauge, and that's a fundus picture which was taken while starting. You can see so we didn't have the red cap, so I used this to vitreous staining with and then the forceps to peel the membrane, just using the RTO 3D 850 and performing so that you can take photographs during the surgery. Thank you.
Very interesting how you managed using the BFO and also to remove and strip those membranes off the optic disc, especially in these patients. They have a different feeling from the membranes. I think they are tougher. Saad, would like to comment on Natarajan's case?
Yeah, sure. This great case. Good to see you, Nati. Yeah, I think the beauty is with the 27 gauge. I think these are great achievements. I have also had similar experience in kids and babies using 27 gauge. I think these cutters, the geometry of the cutter is really beautiful, and I think you did a great job. Thank you.
Thank you. Only thing I could not explain why when I was having maybe one of the explanation my colleague Dr. Jaydeep gave, that giving the Lucentis in one eye, because of the systemic absorption, the other eye got the ROP regressed. Unfortunately, the avascular retina had the vascularization and became normal. And maybe this eye, if you would have done more laser, maybe you could have avoided the surgery. So a lesson to learn is to watch both eyes carefully, and also do the give the anti-VEGF and also do the laser in time.
For ROP patients, Natarajan, how often you decide for, stage 4 on, and how often you decide for, the vitrectomy with the band, and when do you decide to remove the 240 band, for example, in case you used it? After how many years the child is older?
Okay. So if there was a traction all around, I would have used a band addition to this. Since it was a localized traction only in the temporal side, I didn't want to put the band. And if I use the band, I'll make sure it's mildly tightened, and so that being a child, already the ROP babies are prone to be myopic. And if you have the band a little more tight, you'll have high myopia. So to avoid that, I'll have a mild buckle effect. And then I usually remove around the age of 3 or 4. They either just loosen the buckle by just cutting the 240 band. And since I don't use sutures, I actually make a squirrel flap and then pass the 240 band. You have to be careful because the eyes are very small and sclera may be thin. But still, I like to do a scleral flap instead of using a suture. And then there's a Watsky sleeve I use, so no suture at all. So I can cut on one side and just pull it off so that I don't have to just cut and leave it. So one of the recommendations is to cut and leave it. Other is I cut and then I pull it in with along with the Watsky sleeve, it comes off. And I recently had a patient who was done. I don't know why the patient came very late, almost 7-8 years later, but I could still remove the 240 band.
All right. Very cool cases. Thanks a lot. Thanks a lot.
I have a comment.
Yes.
In cases, I usually do like some cases of ROP, and you have to be careful with the posterior hyaloid, because that's one of the problems later, to reoperate patients. And sometimes you think you remove all, and it's not. So you gotta be an eye on these patients and watch all the time and control them, because to reoperate is a possibility, Natarajan.
Yes, I agree with you. Yes, reoperation. And we have already explained, counsel the patient of all the complications, including reoperation.
All right, thanks. And I forgot that Saad has a surgery right now. And, Saad works hard. It's Saturday. Saturday here is a time off for us to, to be around. And I know you're a good worker, because when I came back...
But his weekend is a Friday, right?
Yeah. When I returned from Saudi Arabia, I was here in Brazil, and I was trying to reach our friends back in Saudi Arabia. No, I'm working today on Saturday. I'm working all Saturdays. You work hard, It's like a normal day.
No, yes. Saturday is not holiday for us. So,
Yeah.
so great. Well, thank you very much, and it's great to be here again with all the great.
And we all again want to remember our great visit to Saudi, and we had a good time. And particularly Thanasis and myself on the Sunday had a wonderful day. Thank you.
Listen, Nati, I have a picture of both of you with the Saudi customs. I'm going to present this in one of the meetings. So don't worry about it. I have it.
That will be great. And I want to welcome Dr. Lam Saad, our professor, Dr. Lam, professor from the TVRS as well. And it's an honor to have Dr. Lam. I was missing Dr. Lam. So now he's going to watch Saad's lecture.
Great.
And thanks a lot.
And Saad, we had a great time in Thessaloniki with Dr. Waching Lam and had a wonderful evening with Thanasis' son.
Yeah, Thanasis promised me maybe next year I'll be invited. So I'll be with you. Great to see you, Dr. Lam. So,
thank you.
You are already invited, sir.
Thank you.
Already invited.
Thank you, my dear. So without further ado, I'm just going to share with you this case, which is a little bit unusual. This is an elderly male that came to see me. He's known diabetic for years with uncontrolled, like unfortunately most of our patients. He's got problem in both eyes, multiple laser and injections, and had surgery in the other eye with poor outcome. I'll share with you the OCT pictures. The left eye with counting finger vision is the eye that has been operated in the past with a large ischemic looking macular hole. And the eye that I've seen, he's coming to see me, is the eye with this tractional macular, diabetic macular edema with some thinning in the center. At this stage, his vision was 2200, and I did discuss with him the possibility of surgery, but I told him, you know, there's always a chance that this eye might end up like the other eye, so maybe we should just wait and observe it. We waited for 3 months, but unfortunately the condition just got worse. The traction was more, and the fovea is becoming really thin. And you can see in the top right-hand corner the picture of the other eye with the large hole and the ischemia post-operatively. So at this stage, you know, we elected after a lengthy discussion that we're going to go for surgery, keeping in mind there's a possibility we might end up with the same thing. So this is just the OCT showing the traction with thinning right under the fovea, very thin, you know, disturbed structure of his fovea and macula. So I'm just going to move the video for the sake of time. So after doing a core vitrectomy, I put triamcinolone just to try to address the posterior hyaloid. What I've tried to do here, and here I'm using a 25 plus 10,000 K beveled vitrectomy probe. I'm trying to cut around the fovea to try to release as much as I can, but without you know, doing any vacuum, worrying that if I do vacuum, I might just pull off this very thin foveal cyst and transfer it again into a hole. So again, I'm trying my best to go all around to try to 360 degree to release the traction, and again trying to see if I can get a hole closer to the disc in this posterior hyaloid and try to cut instead of pulling. And I have to say the beauty of these cutters that they're beveled, and the fact that it's 10,000 cut makes it really work very well, and you can certainly insert it into these smaller areas. And you can see again, I'm trying to release that posterior hyaloid. This is a magnified view, and again trying to go around to cut all this posterior hyaloid as much as I can, avoiding to apply any vacuum or traction on the fovea. And it's working just fine. And you can see here, I'm managing to actually have a hole and go around.
Do you like using the macular lens for that to see it closer, Saad?
Sure. What I'm doing here, I'm using the Resight system, and I'm just switching from the yellow to the green lens. And to me, it gives me good satisfaction. So I'm happy. And you see here, I'm trying to open that posterior hyaloid, doing my best not to pull on the fovea. And, you know, just with patience, you will succeed. And you can see here, I've managed to open, and I'm trying to open, go under that, and try to release as much as I can. In this case, and then I did air fluid exchange, and I left him with air. And in this case, I elected not to, of course, peel the ILM. And I have to say, to my surprise, he looked pretty well within a week. Almost all the traction has disappeared. I guess I was lucky enough not to induce the hole, and his vision has really improved. I've seen him now 3 months, and he's pretty stable with a vision of around 20/60 and a very stable condition. The lesson I learned in this case is that, you know, these vitreomacular traction diseases are very common in cases of PDR. You know, if you develop a macular hole, that's not a good idea, and the prognosis is actually very poor. I find OCT very useful in diagnosing and planning the surgery for these patients. I don't know if I should have peeled the ILM, but I was really worried, you know, peeling the ILM may just complicate the condition. So that's my case. I would love to hear what the other panels think about.
Yeah, Dr. Lam, would you peel the ILM? The retina seems so, you know, weak. I don't know whether I would peel the ILM in this case. I think you did enough. But what about you, Dr. Lam?
So that was a very well executed case. I think you're right. I think these cases of vitreal macular traction, especially in the diabetic patients, are challenging, and quite often they are long-standing, and the retina underneath, as you show in your case, has quite a bit of atrophic component to it. So undue pulling with the instrument can cause significant risk of tearing, or in your case, you worry about creating a macular hole by doing too much work on that. The other options, one, I see what you done. Basically, you just take away the vitreous and very delicately trim it off from the surface, and taking advantage of the bevel tip configurations of the cutter. Another option you could consider is taking a banded like a cystotome kind of needle, so using a 25 gauge needle, bend the tip, and then go near the optic disc and slice the posterior hyaloid, because you have a very taut posterior hyaloid kind of structure there. So if you can make a cutting into the posterior hyaloid, and then do exactly what you do, you can do a circular movement around the macula to kind of to separate the residual posterior hyaloid. Because I think in your OCT, there was still a little bit of posterior hyaloid on the surface, but the anterior posterior traction from the vitreous itself has been trimmed. But the main message is that you've done the job. Like that you go in to relieve the vitreal macular traction without creating more damage, and I think that will be that's the lesson to learn. I think you have to kind of balance the risks and benefit, and there's many ways to do this. I'm not sure, especially seeing your result, doing more is better.
Yeah, thank you very much. I totally agree. And I was doing this case with the picture of the other eye in the back of my head. I know I was really worried I'll end up with the same picture, ischemic, large hole that probably is going to respond to anything. So thank you.
Yeah, good ideas, and very well managed. The reason I mentioned the macular lens is that after I do core vitrectomy, vitrectomy, and the hyaloid, I like, even for the hyaloid, I like using the macular lens after I did the core vitrectomy. I like, after doing core peripheral, I use the macular lens, so I get a better view from everything. So I like the tool of the cutter, these cutters from today that we have the port closer to the retina, and also the dual port cutters from Dork, from Alcon, and from other brands. They help us a lot. And these sort of help us use that tool instead of all the time those cutting those scissors and picks. So I think you managed very well your case. Thanks. And I would like to ask if it's available for you, Dr. Lem, you have your presentation. I know it's early for you, probably 4 hours back from here. It's you are, I think you are on Pacific time, no?
Yes, I'm in Pacific time. If you can go in with another speaker, then I prepare
sure.
my video links.
Sasamoto, do you think you go now? Could go now?
Sure. Okay. Can you see my screen?
Yeah, it's pretty cool. How high are you Marcelo, in Bolivia now? It's above
Three 3,600 meters, more or less.
Yeah, and you manage that very well, because I know you work out a lot, and I see some videos in the Instagram and other social media. This is good.
Well, right. At home, I'm at 3,200 approximately. The airport, the La Paz airport, is 4,000 meters above sea level, so it's really high. Okay. So I'm going to talk about adult ROP, the late complications of ROP and surgical treatment. Well, in the modern vitreoretinal surgery, we know that the primary repair of an adult ROP when scleral buckle only alone is performed was failed. So a combined scleral buckle and a vitrectomy is the most appropriate approach. We know that in these cases, the transvitreal traction forces are encountered in these eyes very aggressively, and also aggressive inflammation and the traction of the posterior hyaloid that I mentioned to Natarajan in his case. So this patient is a patient of mine, is with all the consent. He tried to conscientize all the patients with this late ROP to take care of themselves and take care of their eyes. So with this consent, I will show you his case. He's my patient. He's a weightlifting patient. When he usually do that, knowing that he was had problems with ROP. So the right eye was no light perception and stage 5 of ROP with thesis bulbi. The left eye was that we performed the surgery, stage 4 tractional retinal detachment, 2 months evolution. And here's my first approach. So I perform first my scleral buckle, only scleral buckle, scleral buckle 240, and 7 days later, we perform this vitrectomy surgery. To avoid inflammation, these cases are really tough, so we need to separate the two procedures. First, the scleral buckle, and 7 to 10 days, the vitrectomy. So I perform the vitrectomy. You will see retinal detachment, really a lot of traction, membranes, and Hudson?
Yeah, sure. Did your connection,
okay.
Did you lose your connection?
Yes, I will continue.
Okay, okay.
Okay. Can you see my presentation? No?
Yeah. Probably the connection is being variable. It's not it's coming and going.
Now can you see?
Yeah. Mm-hmm.
Okay, I will continue. So we perform this, puts the intraocular lens, and then perform the vitrectomy using 23G. A lot of traction. As I mentioned, the posterior hyaloid is too aggressively in these cases. In the adult ROP, they are really the problem with the retina is that it's really can get rupture really easily. So we use a lot of triamcinolone. This is the first time we use it. We use in this case like 4 times to make sure that the posterior hyaloid was really removed. So as you can see, it's the first triamcinolone staining that we are using in this. There's the second one, and it's still removing and peeling all the membranes and the posterior hyaloid. So it's a really hard and tough surgical, like 3-4 hours maybe, or only in this second surgery. As you can see, the posterior hyaloid is too tough to remove. We use PFL to remove all the periphery, and then find and use in terms of, we found a small hole that was in the superior part of the retina that was producing all of this. We put some laser on it, put some laser on the periphery also, still removing the posterior hyaloid. And in the end, we attach the retina. As you can see, there are some fibrous problems with the macula, and we try to not touch those parts because we're really attached to the retina. We are making the fluid exchange, and then put some at the end silicone oil. Removing the epithelial, corneal epithelium. Here's the part when we are finding the small hole, attaching the retina, putting some laser, and finally silicone oil. So it's really tough cases, this late ROP. Sometimes this patient right now, actually he's no weightlifting anymore, and I think his vision is not that good, but at least we got the eye in back. So that is my case. Thank you.
Thank you, Marcelo. Webhab, are you around to comment on the Marcelo's case?
That's a very interesting case, and I like that we staged the procedure, first placing a buckle and then doing the vitrectomy. And I think the posterior hyaloid detachment was the trickiest part, because there was a bolus detachment and the posterior hyaloid was still stuck even after 4 times injection of tricot, as you suggested. So it's sometimes difficult to find a break. In such cases, you might have a very peripheral break. But well done, well managed, and I hope the patient does well in the future.
All right, good. And I would like to introduce you my case. It's a pretty straightforward case that brings us to a discussion on whether we should or we could do, still be doing and carry on buckles, I heard a comment from a friend of us, a retinal specialist here, and he said, though these buccal surgeries are going to just finish in a while. And I don't agree with that because, you know, I think the combination of scleral buckling and vitrectomy always adds to a better outcome. And saying that, I will show you these cases. It's pretty straightforward that make us think whether we should do something different or just get back to our old buccal habits. And so we are at the Eye Bank Foundation. This is a buccal with peripheral retinotomy and vitrectomy combined. This is our city back in Goiânia. There's a phakic patient, and we started with the buccal. I like doing the buccal, this buccal combined with vitrectomy. I use the 240 band. I like using these tools from the cataract, so they are kind of fancy and help us insert the band easier. The lens is a pretty clear one, and you have very shortened retina up to the macular area, just very so shortened that we have already the continuity of these shortening and breaks. We just made them larger until the retina at the very periphery where it was attached. So we limited the vitrectomy to temporal and a little superior, a little inferior, and unfolded the retina. I like doing much of this subretinal work as well, because oftentimes you have too many cells under the retina, and so when you have the retina free and mobile, now it's possible to use the perfluorocarbon liquid so as to attach the retina like that. It looks pretty clear. And at this time, because this surgery was made some time ago, and we were not thinking of peeling the ILM or not, I would do some ILM peeling for some of the cases with retinal detachment and PVR with some shortening. But this case went well. We could well see the periphery, the free edges of the retinal detachment, and do 2 or 3 rows. It was enough for our direct exchange. The retina kept attached all the time, and we did an angle where the retina was not created the retinotomy, and now the patient got this clear lens up to the end of the case. We are performing the direct exchange of perfluorocarbon liquid for silicone oil. As you see, there is no slippage. I do it very slow. We could go the other way around, and we could probably better off doing that with the air, but I prefer the direct exchange. It's good, the retina doesn't move, and if you start, even the patient is phakic, if you move the eye to the area of the retinotomy without touching the lens and they start from there removing the perfluorocarbon liquids, you are never going to have these subretinal perfluorocarbon, and this is good. And if that happens, if you leave some small amount, a very small amount of perfluorocarbon liquid after positioning, usually it shows off. It displays in the post-operative periods. But now we are removing a very slow procedure at this time. We don't need to rush, and the retina got attached. The question is that, would you do, after doing that, we tighten the 240 band, so you have a support from the peripheral, especially temporal, at the where the detachment and where the retinotomy was. so that creates, this was before, that creates a kind of a wall, and so the retina doesn't stay free at the periphery. It stops where the wall is. The wall is actually the buccal coming from outside. So my point of view, it's always good to do the buccal, but also to create an indentation from the outside to the inside, and so that free retina from the periphery where you did the retinotomy just stays there like that, but then you have a wall, so it keeps more stable. So I don't know, but people are not doing too many buccals, and some people say, some retinal surgeons, no, I won't be doing buccal because buccal keeps the eye too red, and inflammation, these things, and I don't see it like that. So because we do buccals since so long, and that comment that buccal is just something from the past doesn't make me happy. What do you think, Dr. Lam? You still do buccals? Buccal vitrectomy. You remember we did a paperwork with Dr. Diveni, buccal vitrectomy, almost 100%, and I presented that in the research day, saying it was 100%. People were, mad about me because I said 100%, but of course nothing is 100%. But it get, our patients, we had successful rates and not redetaching the retina when we did the buccal and vitrectomy.
Thank you. I think the time when we were doing the combined procedure, the vitrectomy systems and the equipments are a little different. Back then, we didn't have the wide field viewing system to get a very complete removal of the peripheral vitreous and examinations, because we were quite limited in the view using the lens systems. And today, I think with the advancements of the equipment, you can do very well peripheral dissections and examinations of the peripheral retina. Because I think one of the major myths in managing, for instance, pseudophakic retinal detachment are those small breaks. And the buccal often will allow you to address or at least cover those breaks, and you will improve your postoperative success rate. And but I do see the benefit of combining the buccal and vitrectomy, but I think I'm not doing them, and I see many others also don't do them on a regular basis. Buccal, I think, it still has advantage for inferior detachment with inferior breaks, because posturing with the gas after vitrectomy sometimes may be difficult. And whenever you are not able to have a complete removal, or you think that you may have some residual tractions in the periphery, a buccal can also be helpful. I think the modifications of the consideration with the newer equipment, vitreoretinal surgery equipment, makes the decision somewhat different now. You probably do it on selective cases.
Yeah, thanks for the comments. I remember because I lived this era, when I got to Toronto, we had the lander systems, and we went to the periphery with the prism lens and rotate here, rotate there. Whoever lived those times know how it's easier today for us to see the periphery and do things. And I remember that you were starting with the Vogue system. We were already doing here the AVI system, and then things with time moved to the wide angle, and after some years they moved to more macular view for macular holes and things, and this was quite an evolution. What do you think, Mohammed? How was you trained in terms of buckling and vitrectomy?
For me, actually, I am not a surgeon of buccal too much. I didn't do buccal too much. But if I decided to do buccal, I just do it for a children and phakic child. That's it. I never do combined buccal and vitrectomy at all until now. So I feel that if I need to go inside the eye, there is no rule for buccal. This is my point of view. If you need to support the periphery or the anterior of the retina, relax it, the retina at that. So the retinectomy, it's a same goal that you can reach if you do a retinectomy over if you put the buccal from outside the globe. So this is my point of view. So if I just decided to do vitrectomy, I feel that there is no rule for the buccal.
Yeah, good ideas. I have to tell you, this is kind of funny. I was so happy, Vibe that I've been seeing patients and the foundation, and some patients are so chronic that we get too, long to see them, and then they get to the point that they need a vitrectomy, no buccals anymore. I was so happy these last weeks that we did some buccals, and they said, no, you need to do the surgery tomorrow. Let's do it. It's emergency. Let's do buccal. Otherwise, it's going to turn to vitrectomy. And I was so happy that I saw the postoperative day, the indentation and things. And eventually, one of the buccals did not attach well and had this previous PVR, and we had to go for vitrectomy. But then the postoperative period, the retina was attached. You could see all the indentation, even with the buccal from outside. So I know it takes some time, and it's like engineering, like architecture to place those sutures and things, and it takes a while. But with the 240 band, it's not that bad. It goes pretty fast, and it's just maybe 15 minutes extra time. Do you still do buccals, Vibe?
Yes, I do in select cases buccal vitrectomy, and I think maybe pure buccals in, as Dr. Mohammed said, young patients who I can get away with, because you don't know if you can do a good vitrectomy in those patients. You might actually not be able to induce a PVD and complicate matters. So maybe if you can externally close the hole or the break, doing a buccal in those cases are good. I like the technique in which you did not during PFCL oil exchange, you did not place the cannula at the break edge, but still the retina was, did not slip off. So that's a very interesting. What is your way of doing the PFCL oil exchange, Dr. Hudson?
Yeah, could you repeat that for me, please?
Direct exchange of PFCL oil, how do you do that?
Oh yeah, for the buccal?
For the vitrectomy.
For the
direct exchange PFCL and oil, like you showed us. So this is passive aspiration or active aspiration?
Yeah. Passive aspiration, yeah, of course. Because in that case, if the retina is too shortened, and then if you go past the air first, and then sometimes you have more of a chance of having, unless you go very slow, a slippage from the retina and even some air in the subretinal space. So I prefer to do the direct way, the direct exchange, and with that, the assistant goes injecting the silicone oil manually, and at the same time, you start with the backflush cannula right at the periphery where the retinotomy was, or any breaks or holes. But if you have a phakic patient like this one, if you go too much peripheral, you of course are going to touch the lens periphery, the equator, and so it's better that you bend the eye a bit to towards the direction you are doing the aspiration with the backflush cannula at that hole or at that retinotomy. And then you keep moving towards the posterior pole, towards the optic nerve, and it doesn't take much. I'm taking a little longer in 5,000 centistokes silicone oil, but 1,000 centistokes silicone oil, it goes very fast. And I tend to use for these cases the 23 gauge needle, unless I'm on 25. But if you are, because oftentimes we do vitrectomy with the 23, and then we use some instruments 25, but for this exchange, the 25 is so small that it would take longer, and for 5,000 centistokes, silicone oil is not very good because it stays longer. Sometimes the pressure goes so high, and you take a look at the optic nerve, and sometimes you see the vessels are like bumping like that, so it's not good for the patient, for the intraocular pressure. So I do the thing with 23, and it goes pretty well. And for like this case, PVR cases, I usually leave silicone oil, not gas, unless the retina is pretty attached, like that case that Athanasio showed us, and no rolled edges, and very good looking. And then I would use air, but in those cases, in cases that I just showed, I prefer silicone oil. Thanasis, your mic is off.
Mic is off. Okay, may I say something about the exchange of PFCL and silicone oil? There's a technique that is called the dual petal technique that is in the constellation. Where if you have a chandelier light, we can use one hand with the silicone oil tubing in the eye, and the other hand to have a flute needle. So when you put half the petal of the constellation, you just send the silicone oil inside the eye. At the same time, in order not to have sudden or deflation of the eye, you have this infusion line dropping fluid with 20-25 open, still open. So you have also the infusion off. When you inject the silicone oil, you have the flute needle behind, and you remove the peripheral cover. So if you push both the petals, not half the way, all the way down, so you have suction, extrusion. This is not a passive, it's an extrusion system. You have an extrusion and infusion in the same time. So with dual petal and the chandelier light, you can do it immediately. So if you have a little bit more extrusion coming and you have a soft eye, you lift the foot petal and you inject only silicone oil. And then when you see the pressure goes up, as beautifully said by Hudson, then you go to the end of the petal, and then you have the extrusion working at the same time, and you relieve that. So you have a control of the exchange. So remember, infusion on, and at the end, when you finish it, this thing, you can see the eye completely, have a complete feel this way. So you have, it's much easier to do that with a dual foot pedal technique.
Thanks for the comments. This comes from experience. And also for injecting PFO, if you have this dual bore cannulas, you don't have this high pressure. Sometimes we don't have, and they are not available, and sometimes we have to disconnect the intraocular, the infusion from the eye so that PFO flows better. Yeah, I usually do that. And I would like to invite Dr. Lam to present his case. Thanks for coming. I know it's a little bit of switch of time for you now from Hong Kong to UBC in Canada, but I don't know why, but when I see you here, when I see you in Canada, I feel closer to you because,
Yeah,
I remember those times.
In America, yes, it's true. Let me see, I can share screen. Good. And okay, so you see the PowerPoint presentation there?
Yeah, it's good. It's
Okay.
It's not widescreen, but it's it's widescreen.
Okay. So I'm going to share with you an interesting case of management of dislocated IOL, and was working with Dr. Lee from Hong Kong, a case from Hong Kong, and the case has a history of sutured IOL. So people are familiar with this single piece PMMA with the two eyelid, the they use a tenopoline to suture onto the sulcus. And unfortunately for this case, one of the polyene suture after many years has broken after an accidental trauma to the head near the eye, and but the other suture is still intact, so it still hinges there. So the IOL has subluxed but not completely dislocated. So we have the discussions of how do we manage this, and some of the things that we need to concern is that this is a PMMA lens, so if we have to remove it and to exchange it, we'll have to make a bigger wound, because these days we use the foldable IOL, so the wound is half the size of the optic. But to exchange this rigid PMMA, we'll have to make a bigger wound. And as I already told you all, that the other suture is still on, so we have to find the other location of the suture and cut it. And if in the period surgery, if the tenopoline was if the tenopoline is buried well, you may not actually see that well on the surface, and so you have to figure a way to cut the other tenopoline in order to extract the IOL. And when you extract the IOL, you have to bring it into the anterior chamber, and the manipulations in the anterior chamber can cause stress and damage to the endothelial cells. And for these patients, he has history of Fuchs dystrophy, and we really wanted to minimize any kind of stress to the anterior chamber, endothelial cells particularly. So let me just show you the video. Can you see the video now? Are you able to see the video?
No, not yet. The image is a little frozen. The presentation.
Okay, so I haven't stopped playing it. So just to maximize it, and so you can see the IOL is dislocated, hinges. It's not quite focused. You can see the disc there. So what we decided to do, we're going to.
But we are not seeing the video yet. I think.
Oh, okay.
I think because of maybe the connection, maybe you could stop sharing and share again the video straight. I think, yeah. I think maybe
so
some.
Let's try it again.
Some connection mismatch.
Yeah. Okay, let me go to the beginning. Perfect. Okay, so you can see that the IOL is dislocated. You can see the eyelid. So we decided we're going to suture this inside the eye. And so the tenopolines pass through the side where the suture was missing. And you see that it's not focused well, but we grab the suture and cut. So we have a free end of suture on this side, and then we bring that free end of the suture into the eye, and then we try to thread it. So Dr. Lee is trying to thread the suture through the hole, and you can see at the beginning it was a little bit of struggle because the eye has a little bit of fine movement, and you need to stabilize it using the second instrument. So a bimanual method will be an ideal way to do this, and using one forceps to fixate it. And then once you thread through the tenopoline suture through the eyelid, you can bring the suture out. So I'm going to show you, we bring this out with the second instrument. And then what we are doing here is to tie this cut end of the tenopoline to the other cut end of the tenopoline suture from the outside. Then we pull the knot through the eyelid and exit to the other side of the wound. So now you have the now you have the suture that is connected to the needle, and then we insert the needle back into the eye, creating a loop, and we dock it with the 25 gauge needle, so that it is exactly the same kind of 2 millimeter from the limbus, so that you can see we just dock it, and then we just pull the suture that created the loop, and then it tied the haptic back into its original positions, and that's it. So you can see we never enter into the anterior chamber. The procedure actually took very little time. The biggest kind of challenges was to thread the tenopolian through the eyelid, and then it's in about 10-15 minutes the procedure is done. No stress, no trauma to the anterior chamber, and the IOL is back into its original place. So I welcome any comment. This is just one of the different way to fix a interesting and sometimes difficult problems, and I welcome any other kind of comments on the different technique or and things to improve the procedure.
Now you have entered a new era, the era of endosuturing. That's endosuturing. How would you like the name?
It's well, it's intravitreal suturing. Actually, I didn't use any like additional instruments other than, I think, using the chandelier, and I think Thanasis, you love to use chandelier. I think using the chandelier allow you to have bimanual, and I think this case particularly is useful. And using one forceps to stabilize the haptic, use the other forceps to hold on to the suture and thread it through the eyelid, is make it somewhat easier to manipulate. And I think retinal surgeons are very good to work inside the eye, and so we are not into any unfamiliar territories. And I have to say that retinal surgeons are also very skillful in their instrument handling. So this is just an extension of what we do into our day-to-day surgical cases. Just a bit of planning ahead of the time to think of how you're going to rescue that dislocated haptic. Because the truth is that to explant the IOL as a single piece PMMA, you do need a bigger wound. And postoperatively, you have more post-op astigmatisms. And the other thing is that you have to cut the other side of the haptic. And if you can't find the tenopolian from the outside, and to try to cut it inside takes a little more effort to do it. Although you can do it, I think that if you scroll depress to the sclera, to the pars plana area, and then you may be able to identify the suture and cut it. That also takes a lot more manipulation to do. So this is a lot simpler and less time consuming.
Marcelo, I've watched some cases from you with scleral fixation intraocular lenses. Do you have any comments on the surgery?
Just a question, if you, Dr. Lam, if just hypothesizing, you fail this second surgery, and the intraocular lens goes to posterior chamber, which is your next move, which technique?
If the whole intraocular lens dislocated, and I think it will be simpler to try to explant it and then reimplant another IOL, either using the Yamani technique or another type of suture fixated IOL. Because I think the benefit of this particular case is that the IOL still is hinged in one side, so you can manipulate the IOL very easily with the instrument as the technique that I've shown you. But if you have a complete dislocation, you end up have to bring the IOL into the anterior chamber, and I think I don't like to manipulate in the anterior chamber too much. I think the next step will be to explant the IOL.
Because of the wound also, right? It's too...
Yeah. So you need to open the wound to the size of the PMMA. So it's not it's not ideal, but I think if you do a scleral tunnel, you could minimize the postoperative astigmatism without having, like, instead of using a clear corneal incisions to enter to the eye.
Yeah, and those days with these techniques, Yamani, Canabrava, and all the, things are getting fancy. I do the regular way oftentimes. I did it with my anterior segment partner, these Yamani techniques. And we also have to pay attention and think of the future about the materials, the sutures. And do you often do anterior segment, Mohammed Taufik?
No, what I'm doing the secondary IOLs. So but for me, I do only iris screw retropupillary IOLs, and I am feeling that in all types of secondary IOLs, you need to do what you are mastering, because if you are need to change the mind of the way that you need to suturing the IOL, it's totally different games from all of the other types of IOLs. Dr. Lam showed us beautifully how he's suturing the BMA, and you feel that you can do it, but when you do it, it's need a lot of learning curve. It's a learning curve, very difficult, and also in Yamani, and also in sclera fixation, any other types of sclera fixation, iris fixation. So what you are mastering, keep mastering, and because all the type have its pros and the cons. So if you are mastering the one type of surgery, keep on it, and it will give you the best result.
Yeah, great work, Dr. Lam. Always good to watch those lectures from you and teaching. And,
thank you. Actually, I have to just give the credit to the surgeon that I was assisting. I wasn't the one who doing surgery. Dr. Lee, my kind of junior staff in the hospital, is the one who was doing the delicate work. I was coaching her how to do it. So I have to say, we are all very good surgeons, and we just need to kind of understand the steps that we need to do, and we can all do it.
Yeah, that's true. And we are just finishing the meeting. I would like to thank you very much for your presentations. Dr. Natarajan, are you there? Are you still there? Athanasio, I don't know if you were there at the beginning, Dr. Lam, but he's in a very good mood. There are good beaches behind him, and it's Saturday. It's good. I wanna thank you all for coming to the meeting, and these presentations are going to be in YouTube, and actually we are live in YouTube as well, and the great lectures, and we are going to separate and split them for our specific knowledge as well. And thank you very much again. And I would leave today Marcelo to close the meeting.
Well, it was a great meeting. We hopefully can make something special to the Retinawesome 20. We will talk with Hudson I have some ideas that I wanted to talk to you. And thank you everybody for your participation, and have a good Saturday.
Thanks a lot. Thanks a lot. And let's see you, Thanasius, in Hamburg.
See you, Hamburg.
See you there.
Yes, I hope we can make another meeting in a different situation with a little bit of drinking also.
Yeah,
because
sure.
I'm stuck with water today.
We will talk
Okay,
a lot
we'll organize
personally.
something with Nataraja.
All right.
And I think also, how many? Saad is going to be there. You and Nataraja for certain. I don't know anybody else.
Yeah. Yeah, I'm going to be there, Taufik. Yeah? Good, yeah.
Okay. You organize us.
I'll
You're
invite
the
you for a
organizer.
coffee, for a
Yeah.
good coffee there.
Well, strong coffee. Strong coffee. Okay.
Yeah. Thanks a lot. Thanks,
Thanks
Dr.
for
Lem.
everything.
Thanks,
Bye-bye.
everybody.